Ahora hago screen share. ¿Me escuchan?
Sí.
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 Bueno, vamos a aumentar un poquito y mostrar la práctica en más detalle de cómo se implementa en la clínica. Nosotros tomamos una fase distinta de cómo hacemos la rehabilitación. Los centros nuestros son más activos y usamos principales de psychologically informed physical therapy. Ahora, la razón que hablo inglés es porque me olvido de algunos términos. Entonces, si permite, lo voy a hacer en inglés y después las preguntas las hago en español, perdón. Okay. So, pre-COVID-19, en Estados Unidos había desarrollos de telemedicina, más que todo en psychiatry, military, remote rural settings. As we noted before, niche prepaid practices, industrial, and research institutions. Después de COVID-19, cuando empezó, teníamos que resolver muchos problemas, como dijimos antes. We had to resolve many problems, IT infrastructure, reimbursement, staff expertise, licensure, liability and informed consent, and privacy regulations. The good thing is that the US government recognized that this had to be done quickly, so they provided leniency on privacy, reimbursement, and liability. In our specific clinics, we wanted to deliver a value-driven model. We're going to have synchronous telehealth, but we recognized early on it would not equal to the therapy that we deliver at the clinics. But we want it to be meaningful encounter. We didn't want a second-rate type physical therapy.
Disculpa, Joe. En tu computador, apaga la traducción, por favor. Y si puedes hablar libremente nomás, porque tu traducción está siendo hecha en forma simultánea.
Ok, perdón. ¿Dónde lo encuentro? ¿Eso arriba?
Abajo a la derecha.
Abajo. Oh, ok. ¿Cuál
Ponlo
es?
en apagado.
¿Perdón? ¿Esta?
En apagado, sí.
Para.
No, en tu pantalla, en los 3 puntos que están abajo.
Acá.
Tienes que ir al Zoom. No, tienes que ir obviamente al Zoom. Lo que pasa es que cuando uno presenta solamente se ve la presentación. Pero si vuelves al Zoom, vas a ver la interpretación, el botón de interpretación.
Que no lo encuentro ahora.
Tienes que volver a la pantalla de Zoom. There you go.
Eso, perfecto, gracias.
Against interpretation, down there, bottom right.
Abajo para que apagues lo que
Abajo a la
dice
derecha.
traducción apagado y así puedes hablar de corrido en inglés y no te molesta la traducción. Gracias, Joe.
Perfecto, perdón.
Gracias.
Okay. Okay, we're talking about synchronous telehealth.
Sí, vuelve a compartir.
Okay. it's unique and separate than an office visit. The physical therapist would work with a patient surrounding and use what's available at their home, also coupled with guided based education and coaching. Assessments of ADLs.
Joe, por favor, comparte tu presentación. La tienes, te saliste de compartir pantalla, por favor.
Oh, perdón. ¿Verdad que todavía te escucho en la interpretación? Puse off y todavía te escucho. This off. Right. Okay, ahí está.
Quizás puedes apagar el volumen, si no.
¿Está bien?
Sí, ahora sí.
Perdón. Okay. Entonces, going back, physical therapists work on the patient surrounding. We also wanted to mimic general ADLs, advice on progressive phases, and improve functional ADL. Mechanism to continue to promote healing, education, and quality of life was the main goal. As previously noted, physical therapists are considered an essential business in California. And so what this allows too is that the scope of practice allows them to see patients directly without a prescription in California. Now, some states do not allow that, but that's the case in California. So that's what we follow in our state. They can see a patient for 45 days or 12 visits without a prescription. So this is where it became important for us to help triage. So things that were beyond the scope, if it was obvious an infection, a fracture, some patient that was very debilitated, more urgent, we'd refer back to the specialist or clinic. So we'd send to neurologists, to surgeons, and so forth. Again, the concept there too is to help not overwhelm the hospitals. As you noted, many of the hospitals like Johns Hopkins and other hospitals at San Diego were very detailed to open up the COVID wards. Now in California, the hospitals have done really well, except for the border towns. Right now in the border towns of Calexico, Tijuana, and other border towns, the hospitals are pretty overwhelmed because a lot of the people who live in Mexico are going to try to have and seek care in the United States. The hospitals in Mexico are extremely overwhelmed, particularly in Baja California. The key components that we determined that wanted to replicate for us was to have a comprehensive history. We used a very simple EMR that was connected. We didn't use systems that were previously presented, which are nice systems, except it would have been difficult for us to replicate. And also we did not possess systems like Maximo showed or Selenic, which I think are very useful. We used DoxyMe. I don't have any particular financial interest in that, but the reason we use it, it's free. It's completely free and very easy to use. Also, a big healthcare system was using that here in the United States, Kaiser. We vetted a lot of different systems. So we chose Doxy because we can pretty much have a really good image. We can take photo screenshots. We can share information. It's HIPAA compliant. It has all the security. And then we would send the patient's informed consent and have it signed electronically via another document called DocuSign. In addition to that, we'd verify the patient's identity by having a picture of their driver's license next to their face, their facial features. We also had backups. We used Zoom as a secondary because some of the connectivity issues, especially early on, Doxy had a lot of issues. I think a lot of people were getting on the system. Now things have worked really well. We don't have that anymore. We also use hard lines, as I said before, and that resolved a lot of the issues. One of the main things is we wanted to keep it simple. So the way that we train our therapists is to focus on the chief complaint, the largest deficit. You really don't want to worry about too many nuances, and we'll talk about that later, because the main focus here is to make sure they're ambulatory, they're safe, also they're progressing from a surgery, and those things can be accomplished in different manners. We wanted to provide expectations to recovery. We touched about that a little bit, but most therapists that are experienced, you know how a rotator cuff typically recovers. You know what to look for, you know what the red flags are. But the patient doesn't. And if the patient knows those recoveries, you decatastrophize. You help them understand, and really helpful for recovery. By the way, that's true of inpatient therapy too. And you're gonna see that in a lot of the different research aspects. If you could do anything, if you do that alone, a lot of the patients will recover better. Obviously, you wanna educate. You wanna coach and motivate. Both Pablo and Maximo touched on that. Very important, and also the speakers previously. And then we're developing psychologically informed PT treatment models. So everything from motivational interviewing to explaining the patients, listening to them, getting their feedback and input, and incorporating that in the treatment plan. But obviously, you don't do everything the patient tells you. That's not patient-centered care. You have to educate them. They may have some misconceptions, but you have to respect their preferences, or you're not going to motivate them. You're not going to be able to coach them properly. So as before, we address the technology. Then you want to create a meaningful relationship. By all means, don't talk about politics. If you talk about politics, you're going to talk an hour and you're going to miss a rehab session. So again, very importantly, like Dr. Selnick mentioned, there's a lot of psychosocial issues. You know, the patient's fearful. Look at the anxiety we have of catching COVID, of the people around you. We see the numbers. In the United States, we're winning. You know, we're over 2 million and you know, we have the most deaths. I guess we have to do everything bigger and better than everybody else. So it's very important to address the patient. Let them know you're in it with us. Yes, there's a lot of fear, but you're at home. If you clean, disinfect yourself, you're careful when you go out. This is why we're doing the telerehabilitation session. Explain to them what that session is going to entail. And then you're going to have a better connection with the patient, better motivation. From there, again, the expectations to recovery, I can't understate. And you want to talk about their treatment plan. You want to conduct the treatment, and we'll talk about that a little bit later in the presentation. Then summarize the visit, address it. That way it's structured. And that's why we want to train the therapist. We don't want different qualities. Obviously, every therapist is different. Every patient is different, and everybody's special. I get that. We get that. But you want to be able to replicate this at a larger scale. And you can't do that with charismatic care alone. From there, establish an agreement. Make sure the patient agrees with you. You know, I don't like Pilates, but if the patient likes Pilates, they may do Pilates. There's a lot of different things that the patient has preferences. If you don't buy into some of those preferences, as long as it fits the treatment plan, they're not going to do their home program. They're not going to do things. I don't know. I can't get my teenager to do anything, but we're trying with patients. And then establish and agree on the next steps. What are the next steps? What are we doing? How are we scheduling it? Show them the importance that this is something that's going to benefit their health. This is going to benefit their treatment, and it's only a short period of time in their lives. Yes, you had a surgery. Yes, you're in a lot of pain. You can't move your shoulder. But if you think about it, in your lifetime, it's a very short period of time. And so if you get through this now, you're going to be better off. Those are things that we establish with the patient. Once you get the information and you agree on a plan with the patient and you have that rapport, that motivation, we use a lot of asynchronous communication. And on the first presentation, we said we were developing that, but we have developed that. And so we send educational videos after the first visit. And then we quiz them on those videos on the next session, and also their home exercise program. We have videos, we have pictures. We also assess how they do that, how to motivate them. And then we implemented patient-reported outcomes. So now we started gathering information to see if we have a clinical meaningful difference and we're improving patients. So pretty much it's automated. It goes to their phone on an app. They can do the patient-reported outcome. And then the therapist will take information from that patient-reported outcome. Say you do the oswestry or the quick dash or the dash. You take the problematic ADLs and you try to make that part of their treatment plan. Also issues that they have in the house. Maybe they have second-story house and they're having difficulty going upstairs. Well, that better be part of your treatment plan, not so much their knee alignment. So we're looking at bigger functional key issues. Not to say that you can't look at details, but it's really difficult on a telehealth visit to look at every detail. You're not going to palpate. You're not going to worry about various nuances. Remember, you want functional range of motion. You know, you could be missing 10 degrees of shoulder flexion, yet you have full function and no impairment, right? So why would you worry about 5 or 3 degrees of range of motion in the shoulder or the knee or what have you? So we want to keep the patient functional. We use YouTube videos, and then we gather information asynchronous as well by getting the patient feedback. Now, luckily, we use our same EMR that we use, and that was already in there, but we didn't have to purchase anything else. And so from there, the negative comments, we provide to the therapist, and we try to incorporate that in there. And then we look at the positive feedback as well, and then we combine it with our patient-reported outcomes, and then we measure quality, and we're developing that, and then we enhance the program or change whatever we need to do in the program. So get creative when you're treating. Remember, you're not going to do manual. There's been several articles here in the United States about therapists. Oh my gosh, I wish I could jump in the screen and touch the patient. Well, sorry, it's not going to happen. But you can teach patients how to do self-mobilization. There's a lot of Mulligan techniques. There's a lot of techniques that you guys are experts better than I am. Sustained stretching. There's motor control exercises, ADL training, directional preference, and McKinsey. Definitely, those are easy models to follow, and they're more functional than trying to worry a degree range of motion or palpating somebody. Functional movement training, aerobic conditioning. You know, Dr. Salnick noted that, but you need to measure that. So if the patient is stable enough, there's easy ways to measure that, and then you motivate the patient by that. You know, you're at poor aerobic capacity. We got to get you to average. By the way, when you have good aerobic capacity, you can lift more. We publish papers on that. The greater your aerobic capacity, the greater your function generally, and the more you can lift. So that's an important aspect even for an injured worker. Evidence-based guidelines is what we follow. And then we do performance testing. And then you can mix any other thing that you do. There's a lot of things that you may want to do your specialty, but I would pick things that we like to pick things that are more general, more functional, more active, and try to get the patient's general state to complete their ADLs. If they can go to full ADLs or close to full ADLs, you're going to see people with back pain recover. That's in the literature. You're going to see people with all kinds of musculoskeletal conditions recover, despite our philosophy of religion. So these are some of the sample exercises. Functional movement screen. I'm not going to go in detail. You can measure trunk endurance. You know, trunk endurance is something that's very highly correlated to low back pain. This is how we've gotten several research grants, one of the measurements. Aerobic step test. Now with some patients, you can't do that. We had several patients that we can develop a step test and actually do it. And you can measure aerobic capacity. Aerobic step test is so simple. You can get a VO2 measurement, very, very accurate as compared to sophisticated doing it in a lab. And it's very cost effective. By the way, when they're doing the aerobic step test, what else are they doing? They're exercising. They're doing function. And remember, they have lung compromise. So we want to make sure we measure that aerobic capacity if possible, not on all the patients. Time get up and go tests, some of the balance testing, the Bergs. Those are all measurements that you can do, and it could be part of the rehabilitation as you're doing it, motivating the patient, and then you can actually show the patient their objective progress. Or better yet, sometimes they lack progress, they decline, and then they have to be referred to the specialist. The plank test. From all the publications, you really don't know what the heck it measures, but it's very sexy. It's very practical and everybody likes to do it. It does measure general function. It doesn't measure back pain. Runners are strong at it, so are gymnasts, but it is a good test to incorporate. Most people can do it. It's part of their strengthening program as well. And then any other tests related to her specialty. There's a lot of different neuromuscular rehab tests. There's a lot of different tests that you can incorporate to your specialty and to your needs to your practice and the patient population that you have. Other things that we augment is, you know, sometimes, like I said, there's a no-show cancellation rate, or we call and we tried, and, you know, I'd say we're getting about 96% of the patients to be able to use Doxy and use the tele-rehab platform. But sometimes we'll have to do it on the phone. And so you have to adapt, and that may be a phone call, or that could augment the telehealth. We also have asynchronous visits, like I said, where we send videos, logs, information. We have remote evaluations of images, recorded videos. The patient will send us their video of maybe them doing the step tests and showing us their progress, or whatever that is. And we collect that data. Right now, we got to collect a lot of data, so we're able to show efficacy. We're able to show that it is a good quality visit, and it's not a substandard visit. They're not just doing telehealth because we want to make money at this, which we do, by the way. So that's pretty much one aspect. Now I wanted to show you a different aspect. This is what I was telling you earlier that's a bit different. So, you know, we also have a nonprofit organization. And so what we've done there is we write grants and we procure federal funding. We procure funding from different sources. And we're fortunate that we have several funding rounds now with FEMA and Homeland Security, particularly with firefighters. And that's where, luckily, we had experience with telehealth, particularly our principal investigator, John Mayer. He already had telehealth systems, and we're using RedCap to gather information, which is free, by the way. We always try to use the least expensive methods to collect data and process things. And so what we did there is pretty ingenious, to give the right dosage of treatment. You know, you have a lot of patients that come in for physical therapy, but they may have cognitive issues. They may have psychosocial issues that are beyond therapy. The therapist is going to be frustrated. You're going to be frustrated. They may be hooked on narcotics. What good is physical therapy? You know, right now we're talking about the COVID-19 pandemic. Talk about the opioid epidemic and how many lives are lost in the United States. I recently read an article in Spine, and it noted that in one of the cities in the Midwest, it shortened lives by 500 years. So, you know, despite the COVID epidemic, that's not the only issue plaguing society right now. Narcotics have been horrible in spine care. I mean, so many people got addicted and died. But anyways, I'll get off the soapbox. So we triage asynchronously, we stratify, and then you provide the appropriate treatment. So they may get education primarily and training, or they may get education, physical therapy, or they may get education and something for sleep disorders, including a sleep test. They may get medications. So whatever is needed, that's what's going to be provided, not what you have in your toolbox only. We're not just doing physical therapy here. So the triage, then you stratify into where you want to provide the proper methods for the patient. Actually, they're not patients, they're active firefighters. Some have injuries, some are trying to improve their health. But what we found, for example, is that about 95% of all firefighters have some type of sleep disorder. You know, the type of job that they have provides a great preponderance for sleep disorders. And if you have sleep disorders, as you all know, you're probably going to have musculoskeletal pain. You're going to have other physical disorders. So a lot of them are going to end up with CPAP machines. They're going to end up with something. So from there, we go to low risk, moderate risk, and high risk. And depending on the risk level, you get more interventions, or the specific interventions that you need. So this kind of highlights it. So we do a screening. We assign categories by stratifying, and then we put you in the correct low, moderate, or high risk. High risk are going to have more supervision. The low risk and moderate risk are going to have less supervision. Customize their treatment. And these are all firefighters. We have about 400. Now, the exercises that are due are higher level. Remember, firefighters have a very high occupational demand. So we're going to match those demand via the assessments, and then we provide the proper treatment. Now, some of this was being done on site. We did a lot of asynchronous, but now with COVID, we're in the middle of this research project and we couldn't go to the fire stations. So that presented a huge problem. So we have 400 firefighters that we're working on. We had to extend the deadline because of COVID, and then we were not allowed to go to the fire stations because, particularly in San Diego, where we have about 27 stations that we're working with, it's a regional grant, many of the firemen were disproportionately contracting COVID. Because at first there wasn't enough PPE gear, there wasn't enough safety equipment, believe it or not, even in the United States. And they weren't used to it. And so the firefighters, for a short period of time at the very beginning, were getting highly more infectious rates than the general population. So we were not allowed to go to the fire stations. And so what we ended up doing is we had to start implementing more telehealth. And so right now we're basically doing most of the information by telehealth. Now, next week, we're in phase 3 now in San Diego. So next week, we're also going to be going to the fire stations and doing both. So we're doing telehealth and on-site. But we have to test negative for COVID. They have a lot of stricter protocols that we have to follow. And then for injured firefighters, very interestingly, we did a focus group, and it's a very standardized focus group. It's IRB approved. And the firefighters said they would definitely be open to receiving everything through telehealth by physical therapists to treat them. So right now, we're going to see the benefits of this in about a year. Hopefully we can publish the data. We published several studies on firefighters already. And then we submitted another grant for a larger grant for 1.6. Now this grant's going to be 100% telehealth. Obviously, like I said, you want to take benefit of a big crisis, right? So it's, again, it's one of those subjects that's going to be priority. It's going to be fast track. And so everything's going to be done through telemedicine. Hopefully we can develop our systems better as well. So, you know, in short, we believe telehealth is going to continue to evolve in various forms. You know, it's unfortunate that the current pandemic started and we made temporary changes. But in closing, I truly feel, and we truly feel, that the resulting changes in healthcare are imminent, and telehealth is going to evolve in different forms and be very strong in the future. So I hope this helps a little bit better to outline and combining different forms, and hopefully it gives you a better perspective, at least what we're doing in San Diego. I don't think we're the best. I think this is one aspect, our niche, that forced us to do it. But I think you could follow different guidelines from the different speakers and what you do yourself and your experiences, and tailor a telehealth program to your economics, to your patient population, inclusion, exclusion criteria, and follow all your government regulations. And I would say go above those regulations if you can. That way you have something very solid. But I hope this gives you some information to think and help you in your specific rehab circumstances. Thank you.